All right, I see people joining. We're just gonna wait maybe 2 more minutes as people still are joining the Zoom. And if you can, please put your location and role in the chat just so that we know who's here and we can network with one another. And then again, Nicole put it in the chat, but we'll start right at 12:05.
Thank you. I did just fix the chat. I apologize. Our Zooms are starting and not allowing people to put their names in the chat, but I did correct it. You should be able to put your role and location in the chat. Thank you so much.
All right, so we will get started. Before I introduce the presenter, I just would like to give everyone a little bit of information on the Maternal Infant Health Series. So at Wayside Recovery Center, we understand that maternal and infant mortality crisis cannot be adequately addressed without understanding and dismantling racism and bias in our medical and behavioral health systems. We also understand that the complexities of the crisis require community-based responses, and that means not only addressing the stigma associated with substance use disorder and mental illness, but also recognizing the inequalities that persist across the behavioral health system. So the Maternal Infant Health Series is supported by the Minnesota Department of Human Services, DHS, as well as SAMHSA SOAR grant. And Wayside is hosting these free public education Project Echo series with a focus on fostering collaboration between patients, community, and health practitioners to really deliver high quality care to Black mothers, infants, and their families. So today our topic is polling spotlights, so understanding the experience of LGBTQ plus birthing people. Really excited for our presenter, Dr. Carla Alvarado, and I'll give you a little bit of background on Dr. Alvarado. So as Director of Research, Carla ensures the quality of research and the application of asset-based and intersectionality frameworks to the center's research to inform policies and actions that address health inequities. Carla's expertise ranges from health policy, public health, and population health to intersectionality and health equity. She has previous experience in industry, government, academic, and nonprofit settings that includes entities like Evernorth, the National Academies of Science, Engineering and Medicine, and the Office of the National Coordinator for Health Information Technology. Across these settings, Carla has championed, operationalized, and implemented diversity, equity, and inclusion activities, and led projects focusing on health equity. Carla obtained a doctoral degree in public health with a focus on health policy from Oregon State University College of Public Health and Human Sciences. Her dissertation delved into quantitative application of the intersectionality framework to investigate disparities in health outcomes and healthcare utilization patterns. Carla earned her master's in public health with a focus on management, policy, and community health from the University of Texas Health Science Center at Houston School of Public Health. So with no further ado, I would like to pass things over to Carla and welcome you.
Thank you so much to both of you for inviting me to be part of this series. It's very important that, of course, salient topic, but even more important for us to start building these relationships as a center. Just to recap, I just want to say that I'm representing the work of a team that pulled this polling brief together. And so Diane Cassidy is our librarian, Kendall Regueras is senior research analyst, and Sarah Pippenbrick is our communications specialist. So of course, this is always part of a team effort. And before we jump into the polling brief itself, I just wanted to share a little bit about the Association of American Medical Colleges Center for Health Justice, which is where I'm housed. And this center was founded a year ago, just a little over a year ago. And we have in a year done a lot of work. It's been very productive. Our main mission is to broaden that understanding, of course, of health outside of the healthcare space, and being that the AAMC is very focused on doctors-to-be, doctors, residents, a very clinical, medical, teaching, hospital kind of focus, the center is in a way the outreach to the community. And so we hope to collaborate, and we do collaborate with public health departments, community-based organizations, government, other healthcare entities, private sectors such as payers, and community leaders and community members. And so we're trying to provide a space where there can be that type of communication. We want to be that, to provide and foster and foment that type of collaboration. And so through research, analysis, and collaborations, we hope to achieve the health equity with a path of health justice. We have a structure that includes operations, policies, programs, and research, which is the portion that I lead. Within research, we have several activities. We do evaluations as well, but one of the most, let's say, a focus this year and for the next couple of years has been polling. We wanted to get a sentiment of the public sentiment to bring forth, to then juxtapose and share with the research that we find. And so it's our way of keeping a pulse and learning from the community. Albeit it's one form, not the end all and be all, but it's one way that we can manage for now to include the policies, the public sentiment. And so as you can see, we have about 5 polling briefs up to this point. The polling brief that we'll be discussing today, which emanated from a larger poll from pregnancy to policy. And then we also inquire about topics of interest to the center in terms of maternal health, data, and trustworthiness. As you can see, we have a poll regarding what people think the data is being used for, how comfortable are they with sharing the data. We also asked about the state of trustworthiness in different settings and different entities, trust being, a good indicator of following doctor's orders, trusting the system to improve our health. And so we wanted to, in a range of topics, get a sense of what that feels like. And just having passed over Civic Health Month back in September, we wanted to gauge how people think about voting nowadays, given the polarization that we have. And if they're still believing that voting is a mechanism to voice opinion and to, in a way, exert power, we wanted to gauge what people thought about the healthcare setting, perhaps facilitating voter registration, if there's a connection there that the public perceives. And we highlighted a couple of entities that have, made a space for, hey, healthcare settings can help with civic engagement. And we know that civic engagement and the health of democracy and the health of populations is interrelated. So with that said, and right before we jump into the data points, I just wanted to walk you through the processes that we go through internally before we deploy this survey. And so we have a team, of course, our research team. We try to identify internally a subject matter expert, and we work together to define the topic, to validate it, to substantiate why it's of particular importance to the center and to the AAMC. We also, we get together, decide on the topic, frame the subtopics within it. We consult with Morning Consult, which is a vendor that is prominent in the field of polling. They have a large market share and therefore are very efficient in reaching out nationally representative samples. And so we work with them until we tailor the poll and it elicits the information that we would like to elicit. So then expeditiously, Morning Consult deploys the survey, and in a matter of a week, we receive the reports and we also get the raw data so that we can conduct our own analysis and we cross-check the data that we get. We make sure everything's in line. We do crosstabs. We kind of investigate and see what patterns are surfacing. And then from there, we decide which most salient points to feature in the brief. So the briefs that you're seeing are maybe a quarter of the information that we elicit. And because, we have a limited amount of time and space, but we do focus on the most salient points to share with the public. And so in particular to this polling brief, in April, we deployed a birthing experiences poll. And so 1,200 individuals who made up a nationally representative sample who had given birth in the last 5 years shared this poll and they answered it, they participated. Now for the polling spotlight, we noticed that 13% of those 1,200 identify with the LGBTQ plus community. And so knowing that there are inequities based on the belonging in this community, we decided to do a comparison of responses between the cis heterosexual group and the LGBTQ group, just to see the contrast, to see if there were contrasts and then what kind of contrast we were able to find. And so in this first slide, you see the results of that question. We asked what was the quality of their birthing experience? Was it excellent, good, fair, poor, or very poor? And so 20% of the larger sample they mentioned about, a fifth of them said that they had less than a good experience. And so 20% out of the 1,200. But then when we look at the LGBTQ plus community compared to the cisgender heterosexual community, we see that that number is substantially higher. Then when we look by generations, we see that even millennials had even more, reported a worse health birthing experience than did the cis heterosexual millennials. And then when we look at income, we know that income, of course, mediates pretty much all health processes. We saw that we saw that disparity, that inequity. So thinking in an intersectionality term, right here, we see that the LGBTQ community reports these worse experiences. But then when you layer on the age, and then when you layer on income levels, you see that there are even disparities within those groups. Now here we can sadly see that when asked if they felt that discrimination or bias had played a role in their care, more than 50% in the LGBT community said that they experience that feeling. And not, you know, the cisgender heterosexual, it was only 35%. It's still substantial, right? And then we have to explore what kind of discrimination. We could see it by demographics, but you can see how this feeling can impact seeking care, treatment adherence. And so as much as people say this is a feeling, this is a perception, those feelings and perceptions carry on into the healthcare setting, and they play out there, as I'm sure you know. We also asked about complications after childbirth. And so as you can see, the LGBT communities, the majority of it reported some type of complication compared to 2/3 maybe of the cisgender and heterosexual population. And so when you break those complications down by physical and mental health, again, for the physical health, you see that the LGBTQ community reported almost, they were twice as likely to say, hey, I had a physical health complication and, you know, it affected me. And the same goes with mental health, about 60% compared to that 34%. And so we see this persistent pattern of worse health outcomes, of worse experiences, of complications. We also asked about lactation and breastfeeding. As we know, it's very important to maternal and child health. And we saw, again, that the LGBTQ community experienced more complications with that process. And then more logistically speaking about the practicalities of life, returning to work was more LGBTQ community members reported having issues returning to work than did our cis heterosexual group. And so when we asked about, you know, how do you access care, more than half of the LGBTQ community said that they were reaching out for their prenatal, their birth and postpartum health through telehealth. And so more so than the cisgender heterosexual. And so you have to think about the accommodations that happened because of COVID, the telehealth accommodations that were widespread. And you have to think about that in a way, it opened the access to a lot of sectors that didn't have it before COVID. However, you know, now there's talks about kind of retracting or withdrawing those concessions for telehealth. And you have to think about how will that impact not only maternal health, but health for the LGBT community writ large, given that perhaps telehealth is perceived as a more, you know, inviting or amenable experience rather than interfacing directly. We also have to think about issues of access. And so with that, I'll stop. I know that it's a lot of information really fast. I'm happy to go back to any slide, but if you have questions, please let me know. Nicole or Zora, I'll hand it over.
Awesome. Thank you so much, Dr. Alvarado. It is short, sweet, but potent. What amazing information. I just want to thank you for agreeing to share this research with us. We do acknowledge it was a team effort, but this is such valuable, it yields such valuable information. I'm not going to start with my questions because they're a flurry, but Zora and I would just like to introduce ourselves as we are so excited we didn't share that. My name is Nicole Fernandez. I am the project manager of the Maternal Infant Health Series. And Zora.
Yeah, and I'm Zora Darcourt. I work at Wayside as well as the special projects manager. So
Awesome. Well, I noticed that we have a small group, and often sometimes we'll have a small group and we'll have a lot of other people watch the recording later. So what I am going to do is allow the participants to ask any questions that they have, and I'm going to go through the list and allow people to speak. So if you have a question, please feel free to unmute yourself and ask your question of Dr. Alvarado. I know I have several, and I'm sure that you are not just asking questions for yourself, you're asking them for the communities you serve, as well as if you are a person who might have identified this way, as well as experience some of these similar experiences. So please feel free to unmute yourself. Thank you so much.
Thank you. And I do have to say that our team has both expertise and lived experience. And so we always try to incorporate someone or someone's with lived experience, again, just to do our due diligence. And I do have to say that I have no conflicts of interest to report, and I have not taken any honorarium for this. I'm just happy to be here. And please, if you have any questions, let me know. Thank you, Lisa.
I do have a quick question about, have you guys, this is Brandy. My name is Brandy Fry. I'm from Southern California. I work for Providence Cedars-Sinai Tarzana Medical Center. I'm also began my role as the Diversity, Equity, and Inclusion Coordinator for A1 for the state of California. And so I really, this is really interesting to me. My pronouns are she, her. And hers. And I also teach fetal monitoring, and the A1 fetal monitoring course has incorporated quite a bit of content in and around the LGBTQ community. And it's fascinating. There's a need for education on how to care for persons or people, and also there's such a need within our ministries and our hospitals to kind of conform to consent forms, even having, not saying like the mother, or the father of the baby, et cetera, so forth. And education around breastfeeding. And like you said, do you have any recommendations on where we should start? Well, what did these polls say that the healthcare, how could we do better? I guess that's what I'm wanting to know, is how could we do better to providing good rounded education to our nurses as well as to our patients? What can we do? That's my question.
Sure, and thank you for that question. I think, this poll is, like I said, it's a sentiment. It's what we can capture that's happening in the United States, and we can bring it forth. I can't say that we can generalize it to particular health institutions, et cetera. So my recommendation would be patient satisfaction, right? First, you have to question your intake forms, if they can be, apply the race, ethnicity, language, social orientation, gender identity information. That's first and foremost the most important thing to capture. And we know that there are difficulties disclosing that information, capturing it, but you don't know what you don't know, right? And so if you don't start collecting that information, and then perhaps look at your patient satisfaction surveys, if you have any, and do you see a discrepancy when people identify with the community versus those who don't? Even if it's just a tally number, are those that are very, very satisfied part of the cisgender heterosexual community? And I know sometimes it's a lot of work to set up something so simple as to set up forms with the real SOGI data, and then to have someone dedicated to look at that data. But you don't know where you stand until you ask and you assess it. And so then after that comes, what can we do about it? First, I need to know what my problem is and how pervasive it is. And then I need to know, is it an education? Is it something that we include in our DEI efforts through HR? Is it something that's more fundamental that we have to talk about our nurses and then have a training and, you know, our doctors? Is it something that perhaps we can advocate for in the education and training of these professionals? And so even outside of the healthcare clinician, you know, do you have doulas that are comfortable with these populations? You know, do you have competent care? And competent care can apply to culture, and it can apply to the LGBT community. And so it's a tall order just because you know where the United States stands in terms of healthcare quality and information gathering. So it's not something that is easy, but if you can find out where you stand and then start identifying the steps that you can take to remedy that. Because if you don't know where you are, you don't know where to start.
Thank you, Brandy. Does someone else have a question? I know that I noticed Rhonda Fellows, she is a doula in our community, and she is asking if some of the slides could be used. I don't know, Rhonda, if you want to share a little bit more so that Dr. Alvarado can make a more informed decision. We do at previous ask each presenter to share slides, but we also ask all participants to only use them for their education. You know, that they shouldn't be distributed to anyone else who has not attended the training.
Please feel free to disseminate. This is public information. This is on our website. All of the polls also have, you know, other slides should you be interested in digging around those. So please feel free to use your discretion. If you can, of course, note that it comes from the center, then that's, you know, that's gravy. So thank you.
Okay.
Yeah, thank you. I will go to your website and look a little bit more.
Yeah, and actually, I don't know if maybe Zora or Nicole can share. I shared a PDF.
Yes, so we'll share, we do have a PDF version, and we will share that in the next day or two. And we will also ask you to please fill out the survey that you will receive with the recording. That's all helpful for us in the work that we're doing. Is there any follow-up question, Rhonda, that you might have?
I don't. I was in a different birth meeting, and so I came late. So I don't right now have other questions. But as a I have a doula training. It actually is this weekend, and we do have a section on one day the bias is on racism, and one day the bias is on LGBTQIA plus community. And so when I saw that, I thought, oh my, this is like updated data I can even use this weekend because we talk about this. We do have a trans birth worker who also comes in as a guest speaker for that section, but we like to use facts and update it.
Right, and you can use these as, you know, as discussion points, right? You know, what is it that you experience on your day-to-day life? I used to be a nurse, and, you know, the way you read the research and the way it actually plays out, there is a link there, but having that lived experience and having that knowledge of this is what people experience versus this is what this number says. You know, you need qualitative and quantitative data, but I'll just share that having these conversations opens up a lot. Like, I think I saw someone say in the chat that sometimes you realize your own lack of knowledge or your own, you know, point of opportunity to grow and learn a bit more about that space. And it's enriching to learn and to be as inclusive as we can be. And so particularly when, you know, individuals are in such a vulnerable state, you know, they're not only is it mental, emotional, it's a transition in life, you know, add that to possible social determinants of health or health related social needs that they might have, compound on that any substance use issues. And so it's such a pivotal time for even family health, right? It's not just birthing people health and their child, it's the unit of the family, and that then expands over to the community. So it's a very important work that you're doing, and to think about it in the systems, kind of a perspective. You're not just helping a mom and a child, or a parent and a child. You're helping a family unit and then the community.
Thank you so much. Does anyone else have a follow-up question? We're really good on time. We knew that we would not use the full 45 minutes for presentation, but please unmute, share something about your community or why you even attended today. Everyone should be able to unmute.
I'll share that I'll keep in touch with you, because we are, in a way, right now we are work planning for the next year, and we are focusing on leveraging qualitative data to inform clinicians, to set up the context, to just include that qualitative data and the different forms that it comes in, and the ways it can be captured so that it's meaningful to the clinician, so that it's meaningful for the patient. And so I'll just put that out there so that you can keep an eye out for that coming event. We're hoping to schedule it for May of next year. We also had a maternal health incubator that happened in May of this year, and the proceedings of that are accompanied by a graphic designer that was doing it in real time. And so we will have the proceedings, we will have the visualizations, and we will have an exercise where you can read through what transpired, the salient topics that came out of that incubator, data being needed in this different demographics, so that we can identify inequities, so that we can begin to address them. Qualitative data importance, the voice of community, and this community-focused approach to this, the healthcare mortality issue. And so just plugging that in there so you can keep an eye out.
Thank you. And Dr. Alvarado, one of the things Wayside is going to be doing for our partners, if they are willing, we're trying to figure out just a general agreement that we just want to post that information. So like we could share the website information, and then, say you have something that's coming up really important and you want it to be shared on our website, we're willing to post those things so that people, what we realize is we've created a really broad and national and international network, and we're looking to continue to expand, but we're not the experts in all of these areas, and we want to make sure people are able to identify local and national resources and research that's happening around the country. And so we're hoping to launch that around January 2023. And this would definitely be something that we would want to be able to share if there's an opportunity for people to poll in, right? Using our wonderful web and digital platforms, let's take full advantage of connecting our constituents with you as well. I see someone posted something in the chat. You can unmute. So I'm encouraging you to unmute and ask your question live. It's a small group.
Okay, it is a small group. Okay, so anyways, I was like, I made that comment there about, like the long-term strain of anybody who's LGBTQ in that community, that long-term strain of, being who they are, and then maybe identifying as somebody else. And I know personally, my son who's gay, he shared with me how hard it was for him growing up. And I really, and I was an easy person to come to and talk to about things like this. And so I think about that, and the social determinants of health, when you were talking about that, and I thought, it's just like this lifetime, when you really think about the lifetime of each person and the how they've been a victim of others' attitudes, and maybe the way that people respond to them as a human being. It's just super, it's heavy, for lack of a better word. I did want to make a comment that, you know, I'm not from a marginalized group. I'm white, you know, I really didn't believe in bias till I was told that I'm biased, and I went through my own lived experience of saying, you know what, Brandy, you are biased. And so when I literally, and as an educator, I kind of had to pull back, and I started asking myself, well, how am I going to teach nurses, you know, that we are biased, you know, in order for them to be able to identify and be aware that they are biased, so that they can begin to mitigate that bias at the bedside, so we can improve outcomes. And I'm wondering if any of you guys have thought about ways how we're going to teach people to about bias, because I think one of the biggest hurdles is going to be, you know, those egalitarian values that white nurses have. I mean, just to be straight out and to be direct and have a conversation. Like, how am I going to get it through? I know for us, because I did a study called Challenging Implicit Bias, and I used the flipped classroom. And I read in the minority nurse, it's upwards of 75% of the nurses in the US are white. So we're going to have to be able to speak to these white nurses. A lot of them, when I come to my colleagues and I start talking about bias, they become very offended and defensive, and they throw up a wall, kind of like I did. And so that's, you know, I'm wondering what are your guys' thoughts on that? What is the best way? Have you guys started thinking about, like, how do we just start talking about it? What does that look like to you guys?
So Brandy, one thing I like to simplify, whether you're talking about biases or racism, is to
Yes.
understand that you come from your own cultural group, right? And it has layers. Our cultural group has intersectionality, right?
Yeah.
So I'm of Cape Verdean descent, but when you look at me, right, or what would, I was just reading a book by Viola Davis. Back in the day, they would say interchangeable, all American. What does that mean?
Right.
Right? You know what those mean. So there are terms that we've used in community to label people, and there are terms that we use to separate people, whether it's by social class, income. So just understanding those things helps us to understand bias and implicit bias is happening all the time. The
Yep.
same reason why I color my hair red all the time. I want to be a redhead. I prefer that over another color for multiple reasons. And the unconscious bias, if we can admit that we have bias, that we're even being reflective, as you said, you had to be self-reflective. You had to wrestle with it. And if you can begin to at least open that door, and it doesn't mean personally you're a bad person. It's not about you. And that's what we have to understand. If we are in healthcare, if we are in service positions, educators, etc., you are a servant. And so you have to be willing to be reflective and self-analyze the quality of care that you are serving, which means just like you can make a mistake on a chart, writing, right?
Right.
Entering data, you can make assumptions about people that may not be true. And where we're coming as a recovery center, dealing with people who have substance use disorder, right? We have a leveled family trauma. Ironically, just over the past 2 weeks, I've been listening to people, and I had to correct a colleague who said in her conversation, in jest, said that she OD'd on Barney when her son was little. Well, I had to correct her as a colleague and say, you know what? You can't say that. I know that you didn't mean any harm, but we have no idea who's in this space someone may have lost someone to substance use disorder, right? Young people saying things. We even had people with COVID who shared, oh, I'm just getting over COVID, but I'm still positive in another space and community. Well, they didn't realize they were triggering community members and young people. So it really is that self-awareness of that we're part of a whole community, but how
Right.
we present ourselves and how we show up with our experiences means that we're also showing up with some bias, and to not be afraid to address that. And please, Dr. Alvarado, or please, Zora, please share your response.
Please just call me Carla, and point well taken. Like, it's just what we need to hear. Also realize that you have power, right? Because of your social position, you have power, Brandy. So whenever and there's different levels of this racism, which we like to use euphemisms for: unconscious bias, etc. It's discrimination, and it tends to be racial, so it's racism. It's at the personal level, at the institutional level, at the systemic level. Those spaces that you occupy as an individual set the example, right?
Right.
If you're training nurses, you set the example there through the behavior you exhibit, which
Right.
impacts the nursing students that you have, or the young nurses that come in. Then, if you hold a position such as a manager, if you're in some type of advisory board, you have the power and the space and the voice to look around and say, who's missing at the table? Who are we talking about that is not represented in this space, in this room? And either you can extend the invitation, or you can ask leadership to extend that invitation, noting, and that's part of being an ally, right? It's also at the system level, again, at the system level, data is very important. A lot of people say, for example, like the LGBT community or Hispanics or the Black population suffer from health disparities. No, they're not suffering from health disparities. They're suffering from discrimination, lower quality of care, disdain, not getting, as aggressive as a medical treatment as they should. And so the disparity and the inequity happens at the system level. When you're detecting those, it's because of behaviors that are happening. And so just know that you have more power than you think you do, and know that your voice can be that bridge and can be an ally, and modeling that again at the interpersonal level, at the institutional level, and when you have a chance at the systemic level. And that's how we get there, little by little. And I very much appreciate that you acknowledge the defensiveness that we do face when we are called out, when we're perhaps being not as woke as we can be, not as, it happens. I can make mistakes with pronouns, right? And it's not intentional, and people correct me. And, when people get corrected, it's kind of like a jolt, but push that, past that, and it'll be over sooner rather than later, right? You say, oh, sorry, thank you for letting me know. Thank you for reminding me. And so there's that, I don't like to use the word grace because it's been weaponized, but, I very much appreciate you acknowledging that defensiveness and then pushing through it, because I don't think it's something that we talk about a lot. That feeling that you have, that feeling that you get when you're corrected, or when you're reminded of something, it's not you. That feeling is not you. It doesn't represent you. It's just a reaction that you have to overcome, and then you move forward, right? So I'll stop there.
No, I appreciate that. I'm really working so hard. I'm really working so hard, and I want people to, and I love, Nicole, I really like that, it's not about you. I'm just trying to figure out different ways to speak to people about this, because like I said, a large majority of our nurses are white, and I'm having a very difficult time having a conversation with them with what I know. But I try to keep it going, keep the talk going. People look at me, they're like, you're white, what are you talking about? I'm like, well, I'm telling you that because I'm telling you how I felt. I know how you feel. I understand. And some of the physicians too are talking about it. There was an implicit bias training that we all have to do in California. And some of the physicians in and the nurses are very offended. And I'm like, well, you know, I watched it and I liked it. I told my boss, I said, I love it. It's really well done. It's well put together. They did a great job, but it's incredible how people do throw, they throw a barrier up. I wish there was a way that we could get, I think if we keep talking, it's gonna work itself out. Just like you said, Carla, we're gonna have to just kind of move through that, move past it and keep talking, keep having the conversations and making sure that we bring it to the
But we
forefront.
also have to make sure that we engineer it out, right? It's doing the interpersonal work. It's, you know, communicating with those around you, sharing that message. But when you are in a spot where you can engineer out a bias, then you do it. And I'll give you an example of within nursing, you know, the issues of incivilities, right? And the more uncivil nurses are with each other, the worse the health outcomes. It's been studied, right? And so those incivilities can sometimes also be caused by racial friction, right? And so it's not that I'm telling you to think a specific way. It's if you're going to act this way in this setting, there will be a repercussion in health. There will be a repercussion in healthcare quality. There is a repercussion to the person.
Mhm.
The biases that we have, unfortunately, I had to visit a hospital. They were about to inject insulin on a Hispanic woman in her 60s because her sugar was high. The question was she diagnosed diabetic? The question, oh, no, it doesn't say anything in the chart. So why do you think she's diabetic and she needs insulin? Oh, well, Hispanic, older, right? And so these biases, yes, nurses are burnt out, and there are a lot of things that are the system, the way their shifts are even structured, put so much that they turn the automatic, you know, I'm a nurse, I know what to do. But then, like you said, that bias becomes automated that then hits a very tangible health issue, and that they can cause a health issue, right? So a point of entry for nurses is also incivilities, talking about incivilities and how it can be based on race, and then how they treat their patients, right? Unfortunately, a lot of times burnout affects how nurses treat patients, but they're the main caretaker at the hospital. The doctor comes in every, you know, once a day, if that, if they're not too critical, but the nurses make all the difference. The nurses make the hospitals run, right?
I agree.
Yes, informed consent and confirmed denial. Then you get into the issues of what are you asking them to sign? And why are you asking a patient to sign a consent form when they just either came out of surgery or they're about to go into, they're distraught, they're under duress, they might not be reasoning or thinking through what they're actually being told. And so then you have patient advocates. That's a way to engineer patient protection that also then can alleviate some of the racism that people encounter.
Yeah, no,
And
I
for
agree with
violence,
both of you
yes,
guys
I
are
mean,
saying too.
it's-
And like, it's like, how do we also hold people accountable? So like, we can do all the trainings, throw all the trainings at a person, right? And we can't really control either kind of that self work that somebody has to do. But it's really important, I think, as well, just like to add on, is how can we hold people accountable? Because people's lives are at risk, right? People are dying because of things like racism and discrimination. One question I had for you, Carla, too, about your polling. I know that you looked at some of the intersectionalities, such as, I think you said, age and income. Did you guys also look at the intersectionality of race when it came to LGBTQIA+?
Right, and so in that particular slide, I alluded to intersectionality. What I presented was, you know, LGBTQ cisgender, and then millennial LGBTQ and millennial cisgender. So they're separate. The intersectionality there would have been LGBTQ community who's a millennial and who is lower income, right? So they would occupy those 3 spaces at the same time. But to answer your question, looking at it by race, we're cautious in that what the data we present is statistically significant. And when you start parsing out race, ethnicity, and your cell sizes become smaller such that the estimate that you have is not really representative because the numbers keep getting smaller. And so you're making an assumption based on a small number. And so part of the issue is also, who are you asking the questions of, right? And are you intentional about identifying the populations or oversampling for those that like for example, Asian Americans have a low representation, Native Americans, Indigenous people, Alaskan Natives. Then you have to focus on let's oversample for that. And that's something that we are hoping to work for our next fiscal year, that we can specify if you're working with us as a vendor, we want you to be able to oversample these underrepresented groups.
Thank you. A couple of my questions related to that. I'm going to take advantage. I don't see any questions in the chat or anyone unmuting, but I was surprised and curious about the quality of care they felt they received. And also I thought it was fascinating that the numbers looked like they were doubled in reference to the LGBTQ community in the different subgroups. And I feel like there's almost a map that's kind of provided, like you're saying, to have some topics to discuss specifically, like how could we improve care? And what did you experience? Like looking at some of that clear data to, like you said, to actually do surveys, improve intake forms, like, and then what are you willing to do with that data? I just thought it was really fascinating. And for me, I mean, I would love to even have another discussion just by, I know we're at 12:53, but to go through each slide because it's very telling. And I'm just really curious about education, the intersectionality, if in future you will also match up education just to kind of think about resources, right? Because that's always a question. Well, how much education, not just income? Well, you could be low income, but then do you have money? And we know in Black maternal health, it doesn't matter how educated you are. It doesn't matter your income. It doesn't matter any of those things. And we know across the country, in the United States, African-American women hold more degrees than anyone else. So it isn't for lack of education sometimes. I go back to this informed consent and informed denial of people really understanding what they're undertaking when they're receiving maternal health care.
Right, and then talking about expanding that provider set, right? Is it, doulas? Is it birthing coaches? Is it lactation specialists? How can we build that team? It's team-based care for that mother. And yes, to your point about Black and African-American women not reaping the benefits that other populations derive from the moderators, like socioeconomic status and educational attainment. Even marriage, there are differences in how much a support system like a marriage or a partnership grants, and so those are the perfect examples of when intersectionality also talks about, hey, don't take this intersectionality as a double jeopardy, that because I'm low income, because I am a woman of color, because I might be in the LGBT community member. It says, no, you have power in different structures, you have power in different spaces, but at the societal level, we can see that there are these patterns of discrimination that then affect all realms of life, right? And so one of the things that I do ask people to be careful for is intersectionality does not mean double, triple jeopardy. Intersectionality means that once you take all these identities at the same time, your ability to generalize that relationship or that phenomenon or that process becomes very tenuous. So don't do broad strokes. Don't put a little bit more thought into that disparity that you're looking at. And so, yes, to your point about, having crosstabs about education, when we don't see that it's a statistically significant difference, we tend to we don't highlight it, right? And perhaps that's something that we can make more clear in our polls. It's you're looking only at what in the numbers statistically it came out. That being said, we know that statistical significance and practical significance tend to be different. So it depends what you're using that information for. In this case, for the polling, we're using it to get a sense of the sentiment that is out there, right? We're not saying causality, we're just taking a pulse. This is what people are going through. And then, we look into the research, it's either supported or it's not. Either way, we try to keep it in mind so that with our programs, with our research agenda, we can keep those nuances in mind.
Thank you. And then the last comment I will make, and I will still extend to anyone else who is still here thinking, having a burning question, you can always put it in the chat as well, is I'm wondering about the mental health piece, and if in the next polling that you'll dig a little deeper on the mental health and kind of the intersectionality of when did that occur? Was that a known need, a health concern prior? What did it come during or experience it during, or was it in that fourth trimester? I'm loving that a lot of, Zora and I just came back from a conference in Washington, DC, and they talked a lot about the fourth trimester and mental health and the need for that care model, right? That there should be community resources and supports who can help, but also elevating doulas and midwives being some of that support that they can help alongside throughout their maternal process.
And just on that point, we are looking at mental health and paid leave impact on maternal mental health, and so in November, I don't have an exact date yet, but we will release, it's another kind of data brief, if you will, where our research analyst and the team look at depression pre-birth or pre-pregnancy, and then developing during pregnancy, and then postpartum depression, and how, if at all, paid leave tends to moderate that relationship. Because we know that, the US doesn't have the healthiest of paid leaves for parental bonding time. So we are trying to, again, follow that thread of the structural components that can have an impact, right? Paid leave, if it's a policy, if it's widespread, it will have a population health improvement effect, especially in this particularly vulnerable population.
Thank you so much. Does anyone here, because I feel like we could have had another hour and just went through the slides in front of us. Does anyone else have any questions? There's a new message. Let's see. Nope, just a comment that this is great. I saw some thank yous earlier.
And I'll share with you the incubator videos. If you thought this was good, that is, that is like the cornucopia of maternal health from every which angle, from renowned experts. So I'll send you all the link, and then keep an eye out for the proceedings, which is, in the narrative form. But if you like to play it and work and just listen to it, that'd be great.
Wonderful, wonderful. And I see Reese is saying you all asked important questions, and this was super information. So thank you. Well, I just want to thank you, Dr. Alvarado. And we at Wayside, I'm just going to say we love to acknowledge community and the hard work that you've done. So I can't but refer to you other than Dr. Alvarado. You worked for that. So I want to respect that. And that's important to me in my community, just like Mr. and Mrs. When you've worked hard, we want to acknowledge that and honor your hard work. And I am just so grateful that you answered the call to, you know, share this here, and it's going to live. And I know that this is just the beginning of us making sure that we stay in touch and share resources in the community and bring each other to this great work as we all intersect, right? Because we're wanting to make sure that our community, all our communities are served better, but also this is an education forum for practitioners, and we want them to be able to listen to this and learn and reach out and identify resources and trainings that their teams may need, as well as themselves. So I just so greatly appreciate you for your time this afternoon, and thank you again.
I appreciate you all. Thank you so much for the invitation.
Carla, are you can you share your email address?
Sure.
I know that I'm part of the committee for that they're putting together for California, spit it out, Brandy, the convention that's coming. So I want to get everybody's information, because I really, like Nicole was just saying, we really need to kind of work together to kind of make sure everybody's aware, and we communicate and get the message out that this is such important work that you're doing. I think it's amazing. Thank you so much for sharing.
Thank you all for joining today.
Yes. Thank you, everyone. Please be in touch, reach out to Zora or myself with any follow-up questions, as well as we will be sending you a survey. And again, we thank the Minnesota Department of Health and Human Services, as well as the SAMHSA SOAR 2 grant, state opioid response. So thank you, everyone, for attending. I'm not going to end the Zoom, but I will stop the recording if people would like to share their emails here as well.
Thank you. I've shared mine, and please reach out. And Nicole, if you can share that PDF, that'd be great. And then I'll follow up shortly with those links that I mentioned.
Wonderful. Thank you so much, everyone. Have a great afternoon.
Thank you all. Goodbye.